thanks very much for the introduction. And so under the overall heading of pain, shedding light on inequities of health, today I'm going to speak to you on spontaneous intracranial hypertension, a survival guide for patients and primary healthcare providers. I don't have any conflicts of interest to report. I am a volunteer member of the advisory board for the CSF League Canada. So today the goals or the objectives of my talk are to increase your awareness of issues of underdiagnosis, misdiagnosis, and delayed diagnosis of spontaneous intracranial hypertension, and also to give some insights into how the complexity of the diagnosis and health system issues can add to delays in diagnosis, and also to increase awareness of the actions and resources that can assist both patients and primary care providers as they seek their diagnosis and treatment for SIH. So cerebrospinal fluid leaks can be spontaneous, traumatic, postoperative, post-epidural, after a lumbar puncture, and all these can lead to intracranial hypotension. Today, the focus is on spontaneous intracranial hypertension and spontaneous leaks. I still see articles where they're referred to as rare, but I think more so it's recognized in the last decade that they're underdiagnosed, often misdiagnosed, and certainly there are issues around delay in diagnosis. There are no large community studies looking at the incidence or prevalence of SIH. There is a good study done by Dr. Shivink, who presented earlier to you this morning, that was published in 2007, where they looked at individuals presenting to a hospital emergency department over a 4-year period. And out of that study, they estimated an incidence of, an annual incidence of SIH of 5 per 100,000. The study acknowledged, and study authors acknowledged some that was generally probably an underestimate given the limitations of how they were able to do this study. We see that it's more common in people with a history of inherited disorders of connective tissue. And although my talk today is more around CSF leaks, I think many of the issues that I'm raising and that of underdiagnosis, misdiagnosis, and delayed diagnosis also apply to people with less common disorders such as disorders of connective tissue. And I want to touch on today about, we know that diagnosis and treatment remain a challenge in these disorders. So in the last decade, there have been many advances. There's a broader clinical spectrum is recognized, and other, my colleagues have spoken to you about that this morning and will continue throughout this day. There's improved and innovative diagnostic imaging. There's new entities that have been recognized. For example, a CSF to venous fistula that was recently discovered in the last 5 to 6 years. And at first, although it was thought to be uncommon, it's now accepted that it probably makes up for about a quarter of the cases of SIH. There has been increased awareness in the last decade. The Cedars-Sinai has held two international symposiums on SIH over the last 3 years. There's in Canada, I know there's been presentations at the Canadian Neurological Sciences Federation annual meeting, and that is important because we see multiple neurological specialties, such as from neurosurgery to neurology, that are represented at that meeting. There's also been a Leak Week, first started in the United States and then spread to Canada, and we've had a Leak Week with its attempt to increase awareness both in 2019 and 2020. And certainly in the medical literature, we're seeing increasing publications on SIH. So there are still issues around misdiagnosis, and although there's been great strides, there's still issues around misdiagnosis and delayed diagnosis. Calgary has started an SIH registry, and myself with a background in epidemiology, usually if I would give a talk, I would be pulling out numbers that were collected through a study, but we don't have that for SIH. I think that's something that will change over time. But and I spoke to Dr. Malingerer about the Calgary SIH registry, which is in its infancy and it's yet has small numbers. But they are looking at date of how long the duration from symptoms to diagnosis and from diagnosis to treatment. And from symptom to diagnosis, it could be as short from weeks to as long as 20 years in this registry, and from diagnosis to treatment from weeks to months. And I think the recognition here is that those that present with a more severe case in an emergency department are often much more they get a quicker diagnosis and to treatment versus others who present in other ways. There's also remains issues around lack of services and access to services, with some provinces not having a headache specialist and others with long waits to see a neurologist. And at the moment, there's no randomized controlled trial on treatment, although I'm sure that's something that will change in the near future also. So I've been asked to talk to you today because in the words of the immortal Joni Mitchell, I've looked at life from both sides now. I'm a family physician, and in that role, I had only heard of a post-lumbar puncture CSF leak. I had never heard of a spontaneous intracranial hypertension or a spinal CSF leak. I was aware of the challenges around a complex diagnosis and had many patients with complex diagnosis. And I also was aware of the importance of a patient being their own advocate. As a patient, I live in a small province with limited access to specialists, and my story is like so many others, with misdiagnosed, delayed diagnosis, and difficulties in accessing the treatment that I required. In addition, with a spinal CSF leak, pain becomes a limiting factor in your ability to advocate for yourself, as most CSF patients, leak patients, are well aware. So if I was to look at I'm comparing two systems for you, because I've also had another unusual or less common diagnosis, and having had breast cancer at a very young age. So, and I'm going to pull out some of the lessons that I guess highlight for you some of the lessons I learned from that. So in both cases, the diagnosis was delayed, and I think you know, so I don't think that's entirely an uncommon thing when you have something that is it isn't common. So as physicians, we're often trained as when we're students, and we pull out the most esoteric and rare diagnosis when we're asked by our teacher to present a diagnosis, and we're reminded continuously what's common is common, and that's what we should be focusing on. So I don't think, and I'm sure there's many people here who have hereditary connective tissue disorders who've also encountered this. In terms of the imaging and tests for the comparison of the two, they were multiple and layered in both cases. The difference being, I think, that there's no blood test or no biopsy test for a CSF leak, and with a cancer diagnosis, having a biopsy and something that somebody can look at under a microscope at definitely speeds up your diagnosis and makes it an easier pathway. There were imaging results and imaging interpretations in terms of the comparison between that. There was difficulties in both cases, but there was a progression and a clear sort of outline progression in a cancer diagnosis, with no real clear progression in a diagnosis to inform a diagnosis of a CSF leak. And although I probably thought my team, my multidisciplinary team, was big when I had my cancer diagnosis, you can see here from this slide that when you have a diagnosis of a CSF leak, there are so many people that need to be involved, from your family doctor, a neurologist, often consulting a headache neurologist. You have a neuroradiologist, an anesthetist who will do the blood patch, a neuroanesthetist, and sometimes also a neurosurgeon. So the difference that I found there also was often within the cancer programs or cancer clinics, that multidisciplinary approach is well established, whereas within a CSF leak, it is not yet, and it is quite a fragmented approach. The limiting factors with cancer would be, I think, fear, but I think fear is dealt with and waylaid when you have a clear pathway forward and a team and you know that you're going from one step of testing to another. And with a CSF leak, I think one of the biggest limiting factors is pain and the disability that causes. In terms of a systems approach, I think the cancer is a very cancer diagnosis and treatment is a very organized affair, and that you have a cancer clinic, and within those cancer clinics in the more recent years, and probably in the last 5 to 10 years, you even have a patient navigator. With the CSF leak, there is no support within the system, no organized support. And in terms of the supports that patients need outside the societal supports, I think often the response is, "Oh my God, it's cancer," and that everybody knows somebody or has had a relative with cancer, and so they kind of get it. With a CSF leak, that's not the same situation, and a person with a CSF leak often looks well, but they have a headache, which is something that's harder to put a finger on. So as I mentioned, in terms of delayed diagnosis, I think anytime something's uncommon, that is to be that there's an element to that, and that can be expected. And I think you throw in there with the CSF leak or spinal intracranial hypotension that the symptomatology is varied, and I'm not going to get into that now because others have spoken to that today. And you can often have a normal exam. So if your family doctor or your nurse practitioner has never heard of it, he or she can never diagnose it. So that awareness piece also becomes crucial and leads to that delay in diagnosis. In terms of imaging and tests, I think for that, to have a clear diagnosis from symptoms, or a clear pathway from symptoms to diagnosis, you need clear clinical practice guidelines and a clear diagnostic pathway. And I found with the CSF leak, it was more, okay, well, if this doesn't work, maybe we'll try this test. And I do also acknowledge that this is changing and has changed significantly in the last 5 years. And treatment, once again, cancer treatment, we have clear standardized treatment. And in fact, if I was to receive treatment with a certain diagnosis of cancer today here in St. John's, a friend would be getting the same treatment in Vancouver tomorrow with the same diagnosis. So that standard of care is so important. I do believe that the team approach is a fundamental element in good care, and within a cancer diagnosis, you often because there's that team built in, you can have the case conference that pulls in the radiation oncologist with the surgeon, with the oncologist, and I think that's the benefit of a team approach. In terms of support, I think it's crucial, and it's limited in a spinal CSF leak, and I hear so much of it from people who have contacted me, that inability to, when you have difficulty standing up and difficulty advocating for yourself, and pain and disability are daily occurrence, that this exacerbates the situation. And it makes seeking and establishing and maintaining supports much more difficult. So just to highlight those strengths then of the cancer care delivery system, that I think I hope that in the future we'll come to the spinal CSF leak diagnosis, or is that there be more of a team approach, that there's an ability to have case conferences on difficult or unusual cases, that the diagnostic algorithms would be the same across the country as would be the treatment algorithms, and that there'd be standards of cares and best practices, clinical trials of treatment modalities, support systems within the healthcare system, such as a patient navigator, and also support network setups outside the healthcare system. And I think this is happening in certain areas across the world, but has yet to be achieved here in Canada. Lots of people working hard and delivering good care in where they are and with what they have, but no yet major referral center. So in terms of the whole, I wanted to touch on, because our title today is Pain, shedding light on inequities in health, I did want to touch on the whole aspect of pain. And certainly this is anybody who's had a spinal CSF leak knows that the pain associated with it is quite significant. And it's certainly made, there was no comparison with the level of pain that when I had a cancer diagnosis. I remember my daughter, when I was early on and did finally get a diagnosis, telling me that she had Googled a spinal CSF leak, and being partially thrilled that George Clooney had a spinal CSF leak. And at the time, I remember reading that you know, some quote that he stayed drunk for a month, and I couldn't refine that quote, and I may have remembered it or not remembered it correctly. But I know I did read an article where he said he started to drink heavily to cope with the pain. And certainly that's not something I would recommend as a physician or a patient. So what do you do? What do you do to deal with this? I think I'm not going to get into all the pain treatment and the pain treatment and pain modalities and the access you can have there. I'm more giving you sort of a general overview and information, I guess, that or more opinion than information in terms of how looking back I could have changed things and how I might have survived my journey a little better, and some of the things I did tap into help to help. And I think one of the things is to be aware that when you have something that's not very common, it is going to be a journey, that you shouldn't carry this on your own, that you do need to be your own advocate. You need to build your own team, and you need to tap into other resources. And that's certainly me saying that all these things are necessary is certainly not easy, especially when your head hurts. So how do you build your team? And I hate to break it to you that you're also going to have to probably educate some of that team. And it doesn't need to be big. In terms of your family and friends, I've received calls from patients suffering from a CSF leak who've been very disappointed in support they've gotten from families or friends because they felt they didn't get it. But I think you can always find in your families and friends that one or two people who do accept your illness and to get it, and that you don't focus on those who just can't understand it. You include your family doctor or your nurse practitioner, whoever your primary care provider is, in your team, and that if there's a patient navigator or a client's relations officer within your healthcare system or your hospital, that you may tap into using them. Other healthcare providers such as massage therapists and physiotherapists can be very helpful on your journey, and other people, getting information from other people with a CSF leak. I wanted to put in here about getting angry, because I think getting angry is an appropriate response to injustice. And I've had talk with people living with a CSF leak who are very angry. And I think my advice on that would be to direct it appropriately. Certainly never at yourself, not at your family, especially those ones who get it, not at your family doctor or your healthcare team, and not at this team that your support team that you've built for yourself. You know, I put in here really, because really I'm asking you not to get angry when I hear so many stories of people feeling they're lost in the system, and they're in pain and they're suffering and they're unable to work. But so this is a big ask. But I think we need to remember that all these people are all human with their own failings, and they're trying to be as supportive as they can be with what they have themselves. I would recommend, you know, get angry and deal with it, and then turn to compassionate action. That you understand that they have their limitations also, and you still use them for the greater good, being your greater good. And I would also ask you to reach out to your family doctor or healthcare provider about seeing a counselor and having that support. This is something that's covered in all provinces and territories in Canada. And although there may be a wait for this, you know, it's a good use of your time and use of resources. This is I added in this book because I found this one quite helpful, because really we have a huge reality gap when we have a CSF leak. We've many people have had an active and productive life, and they've been working and raising children, and suddenly they find themselves incapable of doing much of anything at all. And I like this book and this information, and you can also find him online, Dr. Russ Harris, who's a physician and psychologist out of Australia. And he talks about the times in your life when you get that reality slap, and you have that gap between where you are and where you really want to be, and how you deal with that in the meantime till you get where you need to go. And I found this was a very appropriate book and support for anybody suffering from an illness that has a delayed time in diagnosis or treatment. Also, some other things that in my experience were helpful were meditation, and it was a friend that introduced me through a 21-day free meditation challenge. And really, my meditation in days of pain became my time just to, that was, I considered my own time. And when I left the constant negotiation around living with the CSF leak aside and did some meditation. I also found the use of mindfulness very helpful. And once again, just for that limited relief when the days that, you know, you could walk, that rather than spending that time during a walk ruminating on your last appointment or the next appointment, that you actually took that time to hear the river or listen to the children or feel the ground beneath your feet. Another favorite of mine, and somebody who I've recommended to patients long before I faced the CSF leak challenge, was Dr. Kristen Neff, who's a psychologist who talks about self-compassion. I think being kind to ourselves when life is very difficult is very important. I've also added in here several support websites that I think are quite helpful. The Spinal CSF Leak Canada, the American site, which is the Spinal CSF Leak Foundation, the Canadian Facebook support group, and also a US rare disease a website which has a Spinal CSF Leak support group and discussion community called inspire.com. And I think these are great sites to get support and advice and information on. And I think you need to balance it out though, and with all the other supports that you can find. So your primary care provider, and I've asked you to be a patient with them and to be responsible or partially involved in their education. And this is a big ask, really. But I think you have to accept that they're used to seeing what's common is common. And they're going to have difficulties making your diagnosis if they've never seen a case before. They see one case and they'll never forget it, and they'll never miss another diagnosis. But with the varied symptomatology that a spinal CSF leak presents with, and also the normal exam and the difficulties with the different diagnostic imaging, it really is a challenging and complex condition. He or she is human, and at the very least, they do want to help you and find a diagnosis. That's what their training is. And as a human, they'll also become frustrated with you on your behalf for when they can't get that diagnosis and action that you need. So that there within lies some of their frustration. And it's okay to bring an article or other information to your primary care provider. And it's there's articles available on the Spinal CSF Leak Canada website. And I know I judiciously avoided going to the emergency room, but I know the one time when my family doctor did send me in, I carefully had folded in my jacket pocket Dr. Kranz's article on the 10 myths of spinal or of SIH. I did, as a day, and Bahari had asked me previously to do a short video for them on how you would work with your family doctor or your primary care provider. And so this is just a short video that you can access on the website, which talks really about how your doctor comes to make a diagnosis, how they think, how they ask you questions, and how they formulate a diagnosis, and how you can, and having that knowledge yourself, how you can support them and help them and in making that diagnosis. So I guess the summary on this is not an easy road, and it's for the lucky few, it's a shorter road, but it's a long road with many roadblocks. And for the family doctor, my advice is that they'll be prepared to be confused at times. And I know on several occasions I also confused my family doctor, and especially when I would be trying to figure out if I was in high pressure or low pressure. And so they also, your primary care, as a primary care provider, you also need to know you don't need to carry this on your own, that you reach out to various specialists, and if you can't get help from one, to then go to the other. I know that in my own circumstances, it turned out to be the local neurosurgeon who had the knowledge and had some knowledge on CSF leaks, and was quite helpful to my neurologist who'd never seen a case. And in terms of underdiagnosis, if you think of that incidence rate of an annual incidence rate of 5 per 100,000, I live in an area with roughly a population of 520. So there should be 25 cases of me a year. And my neurologist, who'd been in practice for a long time, I was his first case. And as a physician, you can reach out and use other healthcare professionals, massage, physiotherapy, psychology. See the patient regularly in follow-up. And I think this is something that my own family doctor recommended, as I was not good about going, and in my darkest times, I guess, in going to see her regularly. And afterwards, she said really that was something perhaps I should have been better about. And I would recommend that. And as a family physician or nurse practitioner, if you hit a roadblock, then you really need to try new avenues. The roadblocks that you'll get, I think I've pretty much touched on them all. It's the difficulties in diagnosis, and in what's the appropriate imaging, diagnostic imaging, and what's the next steps. We know that a negative scan doesn't always doesn't rule out the diagnosis. It can rule in the diagnosis, so a positive scan is very helpful, but a negative scan doesn't rule out the diagnosis, and that's something that needs to be remembered. And finding a neurologist that then can perhaps, if they don't aren't comfortable with the diagnosis, that then can reach out even via virtual care to a headache specialist. And then there's sometimes the roadblocks in actually organizing an epidural blood patch, when that is done by the anesthesiology, and needing them to connect up with the neurologist in order to get that. And that's why I think so much that whole team approach is so essential in a condition that is complex and requires multiple specialists for care. And I think the thing to remember as primary care providers is that although we practice by do no harm, when you have a challenging condition and one that has that is not fully understood to date, that you also practice by the motto to leave no stone unturned. And finally, I wanted to touch on the Malingerer, and the Malingerer being somebody who is felt to not have any underlying pathology, but has a condition, but is pretending to have a condition, if you like, because they are trying to avoid life or work or other circumstances. And I think this is perhaps the greatest inequity of all. And I raise I raised this topic at the end because I do think sometimes in medicine, when we're faced with something that is unknown or we don't understand, and in our own frustrations, it can be shifted back onto the patient, and that they really couldn't have anything wrong with them. And I think this is an issue with spinal CSF leaks and other conditions that present rarely, that don't have an easy diagnostic pathway. I know for myself, after my symptoms worsened after lumbar puncture, and I was unable to stand up, was one of my rare trips to the emergency department. And a friend who was also a breast cancer survivor saw me there and came over quite distressed that I was there. I was already having issues with, needing to lie down in a busy emergency department and being quite distressed. And when she, having to say to her, please don't show me any kindness, because I can't be the woman who's crying and emerge with a headache if I want to get serious help and care. Now, and that perhaps may have turned out to be some of my prejudices and the difficulties reflective of the difficult pathway I'd been on in getting my diagnosis, because I must admit that everybody in Emerge, all the physicians and nurses that I encountered that evening were wonderfully supportive. I often think back to my days as a clinical clerk when I worked in a small community to visit a gentleman who was in his 30s at that time, who had gone to bed at 19 And I remember him well when the physician would do a weekly visit to him. He was well tended to by his mother and sisters, and he was tall and thin as he was stretched out in his bed. And after my own journey, I often wondered if he was somebody who was a Marfan syndrome, who had a spinal CSF leak. Of course, I have no idea. And lastly, I want to share a picture with you, and I guess this was something that was very striking for me. I went to a talk about the history of medical care as it was delivered in Labrador. And at that time, in the 20s and 30s, there was a coastal boat that would go into communities, and patients would come out onto the boat, and they would actually be seen on the boat and receive their diagnosis or treatment. And when I went to this talk, the person who was giving the talk talked about how one patient was carried on board the boat, and that you know, when the assessment was done, that the community knew what he was, and he was determined to be a Malingerer. And this is the picture, and I think the look on his face, and the broader picture that you can't see here was the boat crowded with people waiting for a diagnosis. And I know I was had just received my own diagnosis after a difficult journey, and I thought, there, but for the grace of God go I. And the disappointed look and dejected look on this gentleman's face has never left me. And so I do think that that leaving no stone unturned and finding a diagnosis for our patients is very important. I think now in the year 2000, we would look back at somebody who was given that diagnosis in 1920s, and we would think that he probably did have something significantly wrong with him. And I would think that even today, a patient presenting with symptoms of spinal CSF leak or spontaneous intracranial hypertension in Davis Inlet would still encounter many difficulties in getting their diagnosis. So to conclude, I just want to say that I think there's been great strides in the diagnosis, the treatment of spontaneous intracranial hypertension. You have today speaking to you many of the leaders in this field, and the incredible things that they have done for patients in the last decade is wonderful. And I think that you know, and I know that that there's talk of, you know, having a more systems approach, and with that, and I think that's important. That there's, in terms of a goal of uniformity of diagnosis, treatment, and support, that there with a complex illness, that there be a team approach with evidence-based decisions and research, and clinical practice guidelines for treatment and diagnosis, and always, you know, innovation. I know that this is happening across the country and in the United States, innovative ways of looking at, trying to find a leak, to localize it, and to treat it. And also that there are referral centers, which means that you have the expertise all in one place, and that there's thoughts and work on that happening in Canada, and that I think that there's the importance of patient navigators and supports are also being considered. And I guess my final comment would be that at the moment I'm working as a medical officer of health on COVID-19, and it brings to light many of the lessons that I learned when dealing with two uncommon conditions in my own health history, that really we have to be open-minded and show lots of humility in the face of anything that is novel or poorly understood. And I know certainly with COVID virus, we change our outlook and our approach every couple of weeks, it seems, as we get more information and to control about the virus and how to control transmission. So I want to thank you all for listening today, and I wish I had more hard numbers to give you on some of the topics that I've spoken to, and this is more really overview of my experience, both as a physician and a patient, and I take this time to wish you every success on your own journey. Take care.